Okay, this is going to be the first series of lectures that we're going to do for the 2014 Paramedic Refresher through Trotwood Fire and Rescue. The first lecture is going to be over patient assessment in the adult and pediatric patient. Just a little bit of information on confidentiality, and its training materials contains confidential information protected by Ohio's peer review privilege. All information should be maintained in a confidential manner consistent with this privilege. So if you see any pictures of anyone that you recognize or any patients that you have transported, please do not let anybody else know, and please keep it to yourself. Our objectives for this lecture are going to be discuss the reasons for forming a general impression. We're going to prioritize the care and determining the transport during initial patient contact. We're going to differentiate between initial, focus, detailed, and ongoing assessments. We're going to describe physical examination, both a medical and a trauma patient. We're going to discuss the components and the importance of an ongoing assessment. And then, given various case studies, we're going to provide the appropriate patient assessment for each. All right, so where does patient assessment begin? Does it begin with dispatch, medical patient, the trauma patient, the first impression? So typically it starts way before dispatch. We have to be ready to assess our patients, and I've discussed this many a times, and I'll repeat it probably many more times. We have to be good medical detectives. In other words, when we walk in, we have to have a good general impression of our patients, whether it be a medical patient, whether it be a trauma patient. We have to be good at looking at somebody and saying whether they're sick or they're not sick. Because if they're sick, we know that we're going to need to load them into the medic, and we're going to need to get to the hospital, because typically they're going to need more than what a paramedic can provide. If the person doesn't look as sick, then that's when we start doing our patient assessment. And sometimes those that don't look sick end up being sick. So, don't be disguised by that. All right, so just a quick scenario. Medic 107 responds to Hilltop Road, at Jumpers Pass, and a report of a truck on its top. Police and fire rescue are also responding, and Medic 107 is en route at 2:48. So probably just getting out of bed in the morning. All right, and it's kind of hard to see, but yeah, that's a truck. So it is on its side, and it's in bad shape, and this is what we pull up on. So what are we going to do? How do we assess this? What do we need to do? We need to worry about scene safety. We need to make sure that we're safe, make sure our partner's safe, and we make sure that truck's not going to roll over on us. So we need to approach that truck from an area where we know that it's not going to roll towards us. It's actually going to roll away from us. And then we need to start trying to get just a good impression of the scene. Are there fluids down? Is there anything that's going to hurt me before I try to even get to the patient? Is the patient yelling? Is the patient ejected? All right, so now we're dispatched for a report of a child with an illness. His 7-year-old brother meets the crew at the driveway. Says my little brother has a rash on his face and he just doesn't look good. All right, so this is what you find. So I got a pretty decent rash. You can see his lips are fairly swollen. Just looking at him, is he sick or is he not sick? Get that general impression. There's no doubt he doesn't look good. He just looks sick. 1, he's very flush. He's got that rash on his face. 2, his lips are swollen, so we need to know what that's from, whether it's an allergic reaction, whether it's sun poisoning, whether it's a new detergent, whether it's a medication. And also, he's not looking at us. He's kind of looking away from us. That's a good indication that something's just not right. Typically, kids are not going to just look away from you. They're typically going to look at you because they want to see what's coming at them or who is coming at them. All right, so allergic reaction is resolved. Same little boy. So this is him before, looking fairly sick, not feeling good. And this is him after he gets some care at the hospital. So whether it be Benadryl, whether he needed the epinephrine, if he had any kind of laryngoedema, laryngospasms, any kind of swelling of his tongue, difficulty breathing, dyspnea. So this is what he looks like after he gets a positive treatment. All right, so here's that assessment from a patient's view. This is something that I preach all the time. If you can get down to the patient's level, nothing's scarier than having the worst day of your life. You have a medical emergency, whether it be a trauma problem or a medical problem, and all you get is somebody over top of you saying, "What's the problem? What's wrong with you?" If it's 2 o'clock in the morning, half the time they feel bothered they even got you out of bed, and they hate that they bother you. So now you're standing over top of them, you got a bad attitude because it's 2 o'clock in the morning, or you're standing over top of them and you're overpowering them. So you need to get down to their level, get to eye level, whether it be a child, or that's a geriatric patient, or just an adult patient. All right, so what's in our toolbox? So we got that standard BSI, right? Okay, so we got our first in bag. Typically we're carrying a stethoscope, we got BP cuffs, we got our pulse oximetry, our glucometer, any kind of equipment to correct our breathing problems. So we got our oxygen cylinders with high flow oxygen. We've got bag valve masks, we've got OPAs, NPAs, and then in the back of the medic, we've got our cardiac monitoring, we got our capnography. Obviously we don't carry Dopplers in Trotwood, but there are many departments that do carry Dopplers. The backboards, and any kind of C-collars that we need. Alright, so anything else? So what do you have access to at all times? And then 3 of the 4 senses. So we can visualize, we can palpate, and what's the other? So yeah, we need to make sure that we auscultate. So we always want to look at that patient, and when we palpate, palpation doesn't just mean pushing on their stomach or pushing on their pelvis as a trauma patient if you think they have a fractured pelvis. Palpating also can be just putting your hands on that patient and feeling for radial pulses. There's probably nothing better that can tell you if a patient is actually doing well or doing poor than by putting your hands on a patient, getting their skin temperature, getting the skin condition, whether it's moist or it's dry, feeling radial pulses, whether they're present, and if they are present, is it rapid, are they bounding, are they bradycardic? That's going to tell you a tremendous about that patient and how they're doing, and how well they're perfusing, how well they're compensating, or really if they're sick or they're not sick. So this just kind of goes over that general impression that I was talking about. Are they sick? Are they not sick? You have to get good at this. Once again, it's being a medical detective. And then we're assessing for any kind of life-threatening conditions. We need to worry about the airway, the breathing, and the circulation. Like I said, you can look at a patient, putting your hands on them, feeling radial pulses, looking at their airway, talking to them, if they're able to talk back to you without any kind of wheezing, if they don't appear to be dyspneic, if they're not tachypnic. These are the things that we need to worry about. And then obviously we need to put a stethoscope in our ears, listen to their chest, listen to their back, make sure that they're actually moving air and how well they are moving air. And then this is when we decide, can we stay here for a little while? Can we take care of the patient? Or do we need to get them on the cot, get them out of the house, get them to the hospital, because they need a lot more than just the ALS care that we're going to be able to provide. And then, do we start worrying about GCS? Yeah, I mean, there are times that you're going to have to start worrying about the Glasgow Coma Scale. In other words, you've got a patient that is a trauma patient. We need to start worrying about, for the geriatric patient, anything less than 14. If we start, looking at the less than 8 intubate, so there's no doubt that we need to worry about the Glasgow coma. So we need to do that rapid trauma assessment. So your initial transport decision may change after you do the rapid trauma assessment. So in other words, somebody that may look sick, after you start doing thing, you start looking at them, maybe they're not as sick as you first intended or you first thought they were going to be. And vice versa, somebody that's actually compensating fairly well, and you're doing this trauma assessment, and you find something that is life-threatening. Fast systemic assessment for other life-threatening conditions, systematic assessment for other life-threatening conditions. So this is where you put your hands on your patient, look at them fairly quickly, checking radial pulses. If they don't have radial pulses, they have brachial pulses. Do they have femoral pulses? Do they have carotid pulses? Are they talking back to you? Are they staring out into space? Are they looking through you instead of at you? Are they breathing fast? Are they breathing slow? Lift their shirt up. Do they have intercostal retractions? Do they have supraclavicular retractions? How well are they compensating, or how not well are they compensating? And then keep in mind the areas that may lead to rapid deterioration of the patient condition. So we all know that the belly is full of just vascular organs. So a splenic injury, a liver injury, you get a splenic lac, a liver lac, a nick to the bowel, diaphragmatic tears or diaphragmatic ruptures. These are all things that the person can actually deteriorate fairly rapidly. Somebody that's sitting up, we lay them down. to backboard them because they've had some kind of a traumatic injury and they've got a diaphragmatic tear. Now all of those abdominal organs are up in their chest. If you don't think that they're not going to have quite a bit of problems breathing at that time, but that should be a clue number one that, gee, something's wrong. They're deteriorating fairly quickly, but it was also from something that we did to them. And then watch for any kind of distraction injuries. In other words, you got spurting blood from an arm that you're able to control, but then you're so worried about that you miss, the broken femur, or you miss the misaligned pelvis. Now the person's got a big pelvic fracture and they end up bleeding out into their pelvis. So doing that focus history and assessment, it's based on the chief complaint and the findings of the initial assessment. So obviously with a trauma patient with a significant mechanism injury or an altered mental status, we got the trauma patient with isolated injury, medical patients who are responsive, and a medical patient who is unresponsive. So just that alone, basing that on the chief complaint and the findings of the initial assessment, what are we going to do with that trauma patient with a significant mechanism injury or an altered mental status? These people are going to go to our trauma centers. We need to load them up, get them out of the house or out of the car or off the ground, whatever it is, get them in the back of the medic, get them some warm fluids, get them some warm air, cover them up with blankets. They need to get to a hospital because they're going to need somebody a lot better off than what we are, and a lot more training than we have. And then we get the trauma patient with just an isolated injury. So obviously, I'm not saying isolated injuries can't be trauma, but if it's a minor isolated injury, these are the ones we can stay a little bit of time with, but we need to make sure that we do a full assessment on them. And then that medical patient who's responsive. The medical patient who's responsive, typically they can tell you what's wrong, but that doesn't necessarily mean that there's not something wrong that we shouldn't take care of quickly, and we don't need to load them up. This just simply means that the person's responsive. Now we've got the medical patients unresponsive. Those are the ones that I don't know what's wrong with them. If they're unresponsive, and I think everybody does a fairly good job with this, if there's any place where we probably fail and we don't get patients out quickly, it's probably those medical patients who are responsive. Sometimes we stay a little too long messing with these people instead of just getting them on the cot, get them in the back of the medic, and doing our treatments en route. So it says little things can say a lot. So many aspects of assessment occur simultaneously. So looking at their pupils, are they equal? Are they responsive? Are they actually tracking you? Any kind of vision changes? Do they have blurry vision? Do they have diplopia? In other words, they have double vision. Do they have anisocoria? Do they have any kind of problems with their vision? That cap refill. So is it slow? Is it normal? Do they have any kind of clubbing? These are things that we have to look for. And then we got that. We're looking at their skin. Once again, the skin can tell you a tremendous about how sick a patient is. What color is their skin? Is it pale? Are they gray and ashen? Are they blue? So they're not oxygenating properly. What about their turgor? So, that's something that we learn about with the elderly population. Grabbing a hold of their skin and just seeing if it actually stays, see how dehydrated or how hydrated they are. The general appearance of their skin, is it yellow? So are they jaundiced? Once again, are they pale? Do they look tremendously bad? What does it look like? And then obviously the temperature too. The temperature itself, when we're touching their skin, is it cool and clammy? Is it hot and dry? Is it normal? This is going to tell us a tremendous amount about the patient. Their lip color. So pallor, cyanosis, redness. When you get into the African American population, it's a little harder to tell if they've got any kind of cyanosis or they have any kind of lip problems. So typically what you want to do with them is you want to have them stick their tongue out. A lot of times when they start compensating or they become decompensated or hypovolemic, their tongues will start to get white and they'll lose that color. So it's a good idea in any population, just have them stick out their tongue and see what color it is. And then an accessory muscle use. This goes back to our supraclavicular retractions, and it also goes back to our intercostal retractions. Are they belly breathing? Are they sucking, their intercostals in? Are they just sucking their supraclavicular retractions? How much accessory muscle is it taking for them to use so they can actually breathe? Are they tripoding? Is their head bobbing? These are obviously good indications that the person's deteriorating and that we need to get out of the house fairly quickly into the hospital. All right, so we're looking at their vital signs. So when on a pulse, we want to look at a rate and a quality. Obviously, if it's too fast or too slow, that's concerning. And then, what's the quality of it? Is it bounding? Is it normal? Is it thready? So that's going to tell us quite a bit about how the patient's perfusing. Their blood pressure. Do we auscultate versus palpation? If you're going to palpate, we need to make sure that we're palpating on the right arm. Two, we need to make sure that we're actually palpating properly and we're feeling for the pulse for quite a while. Versus the auscultation. Auscultation is a good idea as long as you are not in a noisy atmosphere. Noisy atmosphere, it's probably better to palpate versus an auscultation because you may miss something. And then that manual BP versus that, the NIBP. NIBP is great. It's nice for your repeat blood pressures, but that doesn't mean that you need to make sure that you don't take a manual blood pressure. The very first blood pressure you should take should be a manual blood pressure. Then if you want to let your NIBP take over, then you need to get a manual blood pressure later on. You need to make sure that you're taking frequent manual blood pressures in between your cardiac monitor doing the NIBP. And then your respiration, so it just kind of goes hand in hand with the pulse. Is it the rate? Is it quality? Are they breathing too fast? Are they breathing too slow? Are they using a accessory muscle as a quality? Are they breathing normally? Is it shallow? Is it deep? How are they actually ventilating? How are they oxygenating? All right, so do decap BTLS or something similar to that, whatever mnemonic you want to use. Most of us do use decap BTLS. So we got the patient and injury specific. So we got a simple sprained ankle versus an older patient with difficulty breathing. So just because we've got the simple sprained ankle, that doesn't necessarily mean that, we're going to do the exact same thing for the older patient. We can look at, the deformities, the contusions, abrasion, punctures, burns, tenderness, laceration, and swelling. So we look at all those different things, but that older patient with difficulty breathing, the decap BTLS really doesn't fit them as much because that's more of a trauma mnemonic versus a older patient with difficulty breathing. However, when we get into the sample history, that's where the older patient with difficulty breathing is a little bit more important. So our ongoing assessment, we need to make sure to repeat the initial assessment. We always do stable patients every 15 minutes, and those unstable patients we want to do every 5 minutes, and that's at a minimum. Unstable patients every 5 minutes, stable patients every 15 minutes. You need to make sure you reassess them. That's their pulse, their circulation, and when I say circulation, that's their skin color, their temperature, how much are they perfusing, blood pressures, the respiratory rate, the quality of the respirations, lifting up their shirt, seeing if they have any kind of intercostal retractions, or they have any kind of accessory muscle use. Is their airway still patent? Are they able to still talk to you? Is their voice getting hoarse? Are they starting to get a little stridors? These are things we need to make sure that we are aware of and we actually, check up on. And then always just check your interventions. So if you've got an IV, make sure that you didn't accidentally leave the fluid open. If you have started an IO, make sure that it hasn't infiltrated. And the same thing with an IV. If you have the cardiac monitor on, make sure that none of your leads have popped off. Just check your interventions. Make sure that everything is copacetic with those. So we got the medical patient. So we got two different patients here. Obviously the one on the right, it looks like they're having some kind of a stroke or a Bell's palsy problem. And the female on the left, excuse me, looks like she is holding up that right arm. So these patients, we need to make sure we do a Cincinnati stroke scale on. It's very, very important that we do a Cincinnati stroke scale. And remember, it only takes one of those parameters for that person to fail to be positive for a Cincinnati stroke scale, and for us to call a stroke alert for these patients. All right, so we got the trauma patient. The one on the left is very critical. There's no doubt about that. A lot of interventions going on. And then the patient on the excuse me, the patient on the right is going to be a big trauma patient. Thankfully he's got a helmet on. This may end up being a minor injury. However, it looks like it's probably going to hurt, and he's probably going to be hurting for a couple days. But we need to make sure that we assess these patients. This is a head-to-toe assessment. Once again, we need to make sure we look at the patient, make sure that everything that we're doing is proper, making sure that we are, excuse me, we're not missing anything, making sure that we don't have any kind of distracting injuries, and make sure that we get these patients loaded up, get them to the hospital fairly fast. All right, so how comfortable are you? Experience. Obviously, in this class, we've got a very degree of experience. We have people that have been paramedics for 20 years, down to people that are trying to become paramedics that are basic EMTs that are taking it for the CEUs. So we got a varying, degree of experience versus that confidence. Now this is confidence versus cockiness. Somebody that's cocky, that's when you start missing things, and that's how you get yourself in trouble, versus a sense of confidence. You have to be confident in your skills. If you're not confident in your skills, then you need to make sure you do some remedial training, because the minute you hesitate and you're not sure that you should be doing something you're going to do, that's when the patient may need that intervention. That may be something that you need to do. So make sure that if you're not confident, you either get with somebody that is more senior than you, get yourself into the books, get yourself onto the internet, look up what it is that you need to do, and have confidence in your skills. And then just the general comfort. Making sure that you're comfortable in the back of the medic, or you're comfortable on the scene. If you're one of those people that freaks out at every little scene and gets themselves into a world of hurt, then yeah, you're not. That doesn't mean you're comfortable. That means that you're a spaz, and you need to make sure that you correct that. Because if you show that you are uncomfortable or you are not aware of what you're doing, that makes the patient apprehensive. That's going to make your partner apprehensive. That's going to make the family apprehensive. And you've got to make sure you're comfortable in your own skin. And you get all three of those put together, you're experienced, you're confident in your skills and in yourself, you're comfortable on the scene. Everything else is just a walk in the park. All right, so doing that head-to-toe examination. So when is that appropriate? All right, it should be appropriate on every single call. You should look at every patient from head to toe. I don't care if it's a trauma patient or a medical patient. I don't care if the person has got, just like they said, well, all I did was smash my finger. The victim's prepped and ready for transport. You make sure you look at these people from head to toe, because once again, I don't know how many different times I've seen police officers go to calls on a domestic. We end up going out there for a patient with chest pain. It was totally unrelated. And they were just being aware that grandma sitting in here, was holding her chest. That had nothing to do with the domestic violence between the, boyfriend, girlfriend, or the husband and wife. So make sure that you check these things in this, because you may end up finding an underlying problem that has nothing to do with their smashed finger. So when we're looking at a head and neck, so here's all the different things, and they all kind of go hand in hand, and they kind of intermingle with each other. So we're looking at their eyes. How are they tracking us? How are their pupils? How are their sclerae? Are they yellow? Are they white? Are they bloodshot? Looking at their ears, do they have any kind of fluid coming out of them? Is it blood? If it's some kind of a fluid, we need to test it to make sure that there's no CSF in it. Excuse me. Looking at their nose, same thing. Making sure there's no rhinorrhea. If they have any kind of drainage from their nose, what color is it? Is it blood? Is it green? Is it clear? We need to test it to make sure that there's CSF in that. Looking at their throat and their tongue. Obviously, I'm having a problem with my throat right now. But looking at their throat, are they hoarse? How are they talking? Is their tongue hanging out of their mouth? Are they having some kind of an ACE inhibitor problem? So now they have angioedema. How big is their tongue? Is their tongue white, or is it, a normal pink color? Is there anything on it that's not supposed to be on it? These are things you need to look at. Looking at their trachea. Obviously, we know that the trachea not being midline is a late sign with tension pneumothoraxes, but we need to make sure that we still look at their trachea and make sure that it is midline. Looking at JVD, this is a good indicator of somebody that's having a cardiac event, whether it be they're in some kind of a cardiac tamponade, or we've got somebody that's got peripheral edema and now they're in heart failure. Good indication of that. But also, in turn, this could be a tension pneumothorax for the patient that is a trauma patient. So make sure that these are things that you're looking for. And then subcutaneous air. If you've never felt subcutaneous air, it's one thing. If you feel it, you'll know it. And they say it feels like Rice Krispies. It does. It's just a little crackly. However, sometimes we cause that. That may be from us doing CPR, and now we've punctured a lung. This could be from a attempted tracheostomy and cricothyrotomy, and we end up missing. So, no doubt, if the 80-year-old woman who had, her breasts were sagging, now looks like she's a 20-year-old female with, has had a breast implants, it's probably a good indication that there's some kind of subcutaneous air there, and you're going to need to decompress that to get rid of it. All right, so we're looking at their chest. So symmetry. We need to make sure that their chest is actually rising and falling collectively, making sure that it's not asymmetrical. So in other words, if we got some kind of a flail segment, we need to make sure it's actually doing what it's supposed to do and it rises together. The chest wall diameter, very important for us to look at. And any kind of scars, that tells us if they've had any kind of cabbage before. So they had open heart. Have they ever had a pacemaker in place? So they got the telltale sign of a pacemaker, which is the protruding hockey puck above their heart or below their clavicle. Excuse me, on that left side. Or they have ICD, so they have some kind of an internal defibrillator. These are things that we need to look at, and we need to kind of tells us that maybe they have some kind of underlying condition if they're unconscious and they can't tell us. So we need to start palpating. Once again, noting kind of tracheal position. Make sure that it begins at the clavicles and checking for flail segments. Very, very important. So when we look at the chest auscultation, so if they're diminished, adventitious, in other words, you get the adventitious breath sounds, they're just abnormal, or just flat out absent. So we've got the diminished, we can barely hear them, the abnormal, or the flat out absent. Those people are ill, and we need to get them to the hospital quickly. All right, so just the 4 quadrants of the abdomen. Just real quick, we'll just kind of cover those. So you got the liver and the gallbladder, the duodenum, the pancreas head, the right adrenal gland, the portion of the right kidney, and then the ascending transverse colon. So that's going to be in the upper right quadrant. The upper left quadrant is going to be that left lobe of the liver, the spleen, stomach. We got the pancreas body, left adrenal gland, portion of the left kidney, transverse and descending colon there. That lower right, the lower pole of the right kidney, cecum, and the appendix. You got the portion of the descending colon, the bladder, the ovary, the uterus, the right uter. And then that lower left, we got that lower pole of the left kidney, the sigmoid colon, portion of the descending colon, the bladder, the ovary, the uterus, the left ureter. So I know that seems like a lot, and usually we do a pretty good job of knowing what's where, but just kind of keep it in the back of your mind where these things are, because if somebody takes a good shot, whether it be from a car accident, a baseball bat, a foot, they fall, elderly, they fall onto a step, or they fall onto, a bench, something, or a chair, and it ends up causing abdominal problems. We need to kind of just clues us in on what we should be looking for. Then we're looking at their pelvis and their hips. Many times that's based on the mechanism of injury. So we got the painful palpation of the iliac crest. It's a very vascular area, so just one fracture there, you can lose up to a liter of blood. Deformity and difficult to detect. So this is one of those things where you have to watch on a pelvic fracture because they're not easy to detect. And it's the deformity itself. Sometimes you miss that. You get the little bony patients and you miss it. Versus a hip fracture, fracture in the affected leg usually is shortened in external rotation. That's also with hip dislocations. In the affected leg, it's usually shortened in internal rotation. So fractures, there's usually external. And then the hip fractures the hip dislocations, usually internally rotated on the leg. So make sure you know the difference, splint accordingly, and just realize if they have a hip or a pelvic fracture that you need to make sure that you get some kind of fluid in them. You don't want to try to pump them full of fluids. This is that permissive hypotension thing. But just make sure that you're ready in case they do become hypotensive, that you can dump the fluids into them. At least try to get their blood pressure up to a stable area. Right, and then looking at their back. So visualization of the palpation of the spine and the flank areas, that is very, very important. If you are backboarding these people, roll them over, look at their back before you put them on the backboard. Even if you're not backboarding them, look at their back. Roll them, look at their back. Make sure that there's no stab wounds, there's no gunshot wounds. Make sure that there's no shrapnel. Make sure that they don't have something sticking out of their back or into their back before you try to transport them. Nothing's worse than finding out at the hospital they ended up having a gun in their waistband and you totally missed it. So always make sure that you look at these people and look at their back and their spine and palpate it. It says it's important not to forget this area, as the patient's condition may explain by the large pool of coagulated blood they're laying in. That goes with internal bleeding as well. What kind of bruising? If they've got any kind of kidney problems, if they flank area, they possibly could have that bleeding in that flank area and that bruising in that flank area. That's a good indication to us that we can't figure out why they're becoming hypotensive or why they're deteriorating fast, but we forgot to check their back. All right, and don't forget the extremities. So the signs and symptoms may range from a subtle complaint to the extreme obvious. Remember with the 6 P's that we're looking for the musculoskeletal assessment, there's pain, there's power, there's paresthesia, there's pulses, paralysis, and pressure. Okay? And then that ongoing assessment, that post splinting, make sure that you always check PMS before and you check PMS after you splint anything. That's backboarding or you're splinting an extremity. Then it says, keep in mind, it says all stages of assessment require that you actively and continuously look for life threats and manage them appropriately. We can't repeat that enough. There's no doubt about that. You have to keep your eyes and your ears open for anything that's going to change, whether it be a life threat or just something simple as, a blood pressure change or a pulse change. You have to be very, very aware. Sometimes we just get into a habit of, you'll be all right. We become complacent and we end up missing things. And when we miss things, that's when people can get very sick. So it's important to recognize the need to rapidly and accurately assess the patients and then treat for the worst case scenario. Always make sure that you're ready for the worst case scenario. IVO2 and monitor has never hurt anybody. Making sure that, if you think they need ALS and there's any doubt in your mind, you make sure that you do it. All right, so quick case reviews. We're dispatched to a 2-vehicle motor vehicle collision, and upon arrival, we find a 53-year-old male patient who's the understrained backseat passenger to a high-speed T-bone type collision. He's got impact on his side of the vehicle. All right, so here's our auto accident, quite a bit of damage, and this person is an understrained backseat passenger, so not doing well, especially because the T-bone was on his side. So we find his airway is patent. His breathing is 40 times a minute. He has got a O2 saturation of 76%. Ding, 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 ding. Clue number 1. Respiratory rate is 40, and his SAT is 76. So either he is not perfusing well and he's compensating, or he has got some kind of a respiratory issue. He's got difficulty breathing, crepitus over his right chest wall, diminished breath sounds over the left chest wall. All right, so that tells us that he possibly could have a flail segment, which in turn is causing some kind of a rapid decomposition of him. Now his circulation, he's got a pulse of 110. Could be anxiety. It could be hypotension. It could be a number of different things. Now we did it with BP. His BP is 198/110. Okay, it's not a hypotensive issue, but he could be compensating. His blood pressure could be going through the roof right now because he's either anxious or he's compensating. He's got an active bleed from a scalp laceration. Now, scalp lacerations, you think, Anybody that knows anything knows that the face is very vascular. Any guy that's ever shaved and has cut their face knows that it takes forever to stop the bleeding. Now you get yourself a good scalp lac, especially like in the pediatric population. These kids, they will decompensate rapidly. I mean rapidly with a very simple scalp laceration. So this gentleman is awake. He's got GCS of 14. His trauma assessment is tense, and he's got distended abdomen. All right, so that tense distended abdomen tells me that he has probably got some kind of internal bleeding, because I go back to all of my breathing, and my circulation, which are both extremely crappy. So my index of suspicion, this guy is sick, very sick. He needs to get loaded onto a backboard. He needs to get in the back of the medic. He needs to get to a trauma center rapidly. Things that we're going to do for him. We are going to put this guy on high flow oxygen. We're going to support his respirations, whether it be through a bag valve mask, or if he can tolerate a non-breather, we're going to try to pad his chest wall to make sure that if he does have a flail segment, that we are able to correct that. We're going to definitely start 2 large bore IVs on this gentleman. Not necessarily going to pump fluids into him, but we're going to get 2 large bore IVs, making sure that they're warm fluids, because if he is having any kind of active bleeding in his gut or anywhere else, we want to make sure that we are able to coagulate that blood. Cold blood is thin. That warm blood will start to coagulate like we need it to. And then obviously we're going to put him on a cardiac monitor. We're going to continuously monitor him. We're going to do blood pressures every 5 minutes at a minimum. We're going to do pulse checks every 5 minutes at a minimum. We're going to listen to his breath sounds every 5 minutes at a minimum. We're going to check our airway every 5 minutes at a minimum. So I'm pretty sure you probably are getting a little bit of a Sounds like a broken record, but there's no doubt sick people need to be continuously monitored. Okay, so why can't he breathe? Here we go. We got multiple rib fractures, so including the rib number one. The rib number one, so that's, right there, the clavicle. If this guy's got a clavicle fracture, things that we need to worry about. If he's got some kind of a subclavian artery rupture, that is a big deal. We need to make sure that we watch that. If he's got multiple left rib fractures with the flail segment, now he's got a left clavicular fracture, bilateral hemopneumothoraces. So this guy has got blood and air in his pleural spaces. He's got bilateral pulmonary contusions. So this guy is in bad shape. You can see that they've got the bird there. That is more than appropriate for this gentleman. However, we don't wait on helicopters when we can load the patient up, get him to the hospital. Usually, if you got the call for a bad auto accident en route, put careful on standby. Let them know down at the hospital. They'll get the helicopter ready, the crew's ready, and then you can cancel them. It's just like when we have mutual aid engines and medics coming in. If we don't need them, so be it. But it's much rather to have the cavalry coming than it is to get behind the 8-ball and then not be able to ever catch up. All right, so the second case review. So we get a frosty February morning, so next month. We're dispatched to a fall. Upon arrival, you find a 66-year-old female who fell on the way to the mailbox. So it was around 3 a.m. She got found about 3 hours later. She's still on the ground, and the temperature outside is 2 degrees Fahrenheit. So this sounds like just last week for us, except it's actually a heat wave at 2 degrees Fahrenheit compared to what we just had. So our physical exam, she's awake. She's got a GCS of 15. She's got a big lack on her head. Her blood and her hair is frozen to the ground, and she's not shivering. Okay, so several different clues. Just because she's got a GCS of 15 does not mean she's not sick. She's got a large lack to her head. So we need to find out what kind of medications is she on. Is she on blood thinners? So she's got a lack to her head and she's on blood thinners. This could be a major medical emergency. If her blood or hair is frozen to the ground, that tells me that obviously she's been out there for quite a while. And at 2 degrees Fahrenheit, people don't survive like that very well. Especially if she's just going out in a nightgown, whatever it may be, and she fell. So now, she's not shivering. Not shivering is a bad thing. 2 degrees Fahrenheit, elderly patient, they should be shivering. Once they lose that mechanism, that's a bad deal. You need to make sure that you get this patient into the back of the ambulance, get them warmed up, warm fluids, get them to the hospital. Cardiac monitor is a big deal for this. Get the patient that if we jar them, they're hypothermic, we can end up putting them into ventricular fibrillation. So you have to make sure you're very cognizant of the interventions that you're doing and not trying to pump a ton of fluid into them and not trying to warm them up too quickly. So we get her rapid removal from the surface, obviously. We get her immobilized. We get her oxygen. Definitely start rewarming her. So how bad could she be? She could be really bad. If she fell and hit her head and it was hard enough for her to get a lac and she's on blood thinners, she could already have a subdural or an epidural hematoma. She may have a subarachnoid hematoma. We don't know. However, elderly patients that fall and hit their head, they don't do well because, depending on, how much their brain is atrophied, just that jarring around in their skull that starts, ripping things apart, and they can bleed fairly quickly and get very, very sick from just a brain bleed. All right, so we start rewarming her. She goes to the hospital. She gets that lac repair. She's got frostnip and hypothermia, which obviously I would, imagine she would have both laying out there for that amount of time, and then gets released from the hospital later. All right, so remember, for cold emergencies, we always want to remove them to the warm environment. We want to get that cold, wet clothing off of them. That's very, very important. We do a pretty good job of that, but not only once we get it off of them, make sure we dry them off, okay? And then rewarming. Remember, it's painful when you start rewarming them. Just the other day, I was talking about when I went out and I was scraping my staff car off, and I was only outside for probably about a minute and a half. My fingers just started burning. I mean, to the point where it hurt so bad. I went back in my house and put my hands in front of my fireplace, and it was more painful putting my hands in front of the fireplace than it was just being outside. So just remember, when you start rewarming them, you don't want to rapidly rewarm them. You want to kind of make it a slower process. Consider your hypothermia. Any kind of BLS considerations, so heat packs, making sure you put layers on them. and make sure you turn the heat up. If you're sweating, that's a good thing. If you're not sweating, the heat's probably not up high enough. You need to make sure that you have the heat on as high as it can go, because you need to get these people warm. And then any kind of ALS considerations from a paramedical standpoint: IV access, warm fluids, making sure you put a cardiac monitor, and then pain management. If she's got frostbite or frost nip, she's probably going to need some kind of a analgesic to help her with the pain management. All right, so injuries are usually visible for some time. So if they've got any kind of pallor, they've got, just that waxy look to them, that may be something that actually shows up later on. Hypothermia, we have to be very, very aware of, obviously in the elderly population and in the pediatric population. Any kind of long-term implications. So with legal issues, that's most commonly from missed injuries. So in other words, do a rapid assessment, do an ongoing assessment, make sure that there's nothing we're missing. Nothing's worse, than getting a call from the hospital and them telling you, you missed the femur fracture, or, did you know that they had a pelvic fracture, or once again, did you totally missed that gun in their waistband. So these are things that are very, very important for us. Don't ever put yourself into the situation where you get a phone call from the hospital later saying that you missed something. Chronic pain management. So, unfortunately, we get the med users, or we get the pain med seekers. In turn, that lowers their threshold. So these are the people that, they may be looking for pain meds, and also, when they legitimately hurt themselves, it's going to take more medication than what we have sometimes to even control their pain management. And then any kind of limb loss, that is a big deal. Somebody that's got frostbite, got the frost nip. We just actually were talking about the other day. They had a gentleman that was outside for, I want to say it was like 8 hours, and that negative 40-degree wind chill weather we had, and he ended up having both of his legs amputated up to the knees. And then an anoxic brain injury. So they went without oxygen for quite a while, and now the 23-year-old that's got the heart that's just beating away, it's strong as an ox, they're laying in a nursing home pooping and peeing on themselves because they've got an anoxic brain injury, because they just went without lack of oxygen, and we don't want to be the cause of that, so we need to make sure that we oxygenate these people properly. Right, so what kind of prevention that we can do for the hypothermic patients? Move south, tell them to move south. Our role is injury prevention, so that is, when we go out to do these public talks, we make sure that we tell people to, shovel in the driveways, make sure you watch your neighbors, make sure you salt your sidewalks and your steps. If you are unsteady on your feet, get yourself a cane. If you are unsteady on your feet and you can't walk that well, have somebody bring you food, or try to find a relative or a neighbor that can help you out. Don't put yourself into a situation where you're going to end up getting yourself hurt. On the scene, scene safety for us, it's not just extended scenes. We just had one of our paramedics the other day that I got an injury report for that fell. I actually watched it happen, just kind of icy in the area, and his feet went out from underneath of him. So you got to be very, very aware that you have to be careful around ice and just cold weather, because that black ice can get you fairly easy. And then obviously extended scenes. So if it's, we're outside, whether it be on, an EMS call or on a fire call, you may need to have a rehab unit come out, whether it be Box 21 or our rehab unit here in the city of Trotwood. You need to have somebody come out and help you out. And then having that rehab at the fire scenes, it's very important. Having dry clothes, dry gloves, dry hoods, taking your shoes off, dry socks. I mean, nothing's better than having a pair of warm, dry socks on after your feet have been freezing in your fire boots for 2 hours on a fire scene. Keep yourself warm and dry. Many people recommend this. Having yourself a little backpack, and keep yourself a pair of fire gloves that are dry, socks that are dry, some of those little hand warmers that you break, that are disposable, another hat, a scarf, mittens, whatever, a dry t-shirt, a sweatshirt, and maybe a pair of sweatpants. You put all that stuff into a backpack, you throw it on the rig each time that you go out. If you don't need it, super. But that one time that you're like, oh man, I wish I would have had that backpack with all that stuff in it, that's that one time and it only takes once for you to say, oh man, I wish I had it. And then just trying to maintain the dry conditions itself. Keep yourself out of the rain as much as you can. Obviously, we are not fair weather firemen and firefighters, so we need to make sure that we try to stay as dry as we can and try to get out of the elements the best we can. And if we're cold and the turnout gear that we wear and the uniforms that we're wearing, you can only imagine what the patients feel like when they've got nightgowns on or they've got, shorts or whatever it may be. So be very aware of their surroundings. All right, so any kind of questions for that? Remember, we're looking at the incident, the EMS intervention, and we're in extension. So it's all one big extension. It starts at that incident, then what we do, and then we're an extension of that emergency department. So we need to make sure that we're always thinking, what am I doing? How is this going to help the patient in the long run? So maybe you're not going to give them any fluids from an IV standpoint, but maybe they do need pain management, and at the hospital, they're going to get morphine. Maybe you decide you're not going to give them fentanyl or morphine or, any kind of analgesic, but at the hospital, they're going to end up getting it. You can start a lock on them. Help the ED out because it only helps the patient out. Okay, that's the end of the slideshow. So I appreciate it. You're going to have a quiz on this. So all of the lectures collectively are going to be the part of the quiz. So thank you.